Alright, so let's start our discussion of the INI-CET questions, and I'll largely discuss medicine, but I'll also discuss a few related or integrated, if you will, questions, right? Starting off, before I start off, I will reserve my comments on the difficulty level of paper, and I'll say so why during, as I discuss these questions and after I've finished with them, right? So first of all, there is, they had asked you, they'd given you these 4 values and asked for an ion gap, and it's very simple. You just need to know that potassium is not a component of the anion gap calculation, although it is a part of how what contributes to the anion gap, right? See, how you calculate it is that you take away the sum of chloride and bicarbonate from the concentration of sodium, right? So what's an ion gap is that the fundamental concept behind it is that serum or plasma maintains electrical neutrality. Okay, so it's electrically neutral. Serum, or excuse my spellings there, if you will, right? So serum or plasma maintains electrical neutrality. That means the sum total of all cations, whether sodium or potassium, magnesium, calcium, all that lumped together with all the anions, chloride, bicarb, proteins, sulfates, phosphates, right, hemoglobin, all that lumped together, the sum of all these is equal to the sum of all these. So when you get a gap here, right, when the sum of chloride and bicarb is less than the concentration of sodium, which is what the anion gap is and why it is called an anion gap. If this were a negative figure, sodium concentration was lower than the sum of chloride and bicarb, it would have been called a cation gap, because then it would have meant that unmeasured cations are more, right? But because unmeasured anions are more than the unmeasured cations, which is why you get this difference as a positive value, this is called an anion gap, right? So obviously this is very simple mathematics, class 4 mathematics. It's 35, and fortunately in the exam, even if you included potassium as one of the components, and that choice wasn't there, right? Moving on. Another question on arterial blood gases. They gave a patient situation, a clinical situation where the patient had been having severe vomiting for 2 days and thereafter developed orthostatic hypotension. What had been asked was, what all are you likely to see? It was a multiple correct type question. And so what happens with, so if you know this already, you know, memorize that table or use some mnemonic or hack to remember that diarrhea causes metabolic acidosis, vomiting causes metabolic alkalosis, becomes relatively simple. But then, you know, knowing what all will accompany it is a little tricky. What has happened here is that the orthostatic hypotension tells you that he's vomited so much that he has a volume contraction, causes the renin-angiotensin system, aldosterone system to get activated. Aldosterone, why? Because this will tend to preserve volume. How? Aldosterone will increase sodium reabsorption, right? That's what's going to happen to bring this volume contraction back towards normal, right? And aldosterone is going to reabsorb sodium in exchange for, from the collecting duct, in exchange for potassium and in exchange for hydrogen ions. Loss of hydrogen ions is going to cause metabolic alkalosis, and loss of potassium ions is obviously going to cause hypokalemia. And because this guy is vomiting so much so that he's developed hypotension, orthostatic hypotension, he's also losing a lot of gastric acid. So hypochloremia, hypokalemia, and metabolic alkalosis will be seen in this patient, right? Now they had given respiratory alkalosis, obviously that won't be seen. What if they had said respiratory acidosis, right? Now you would know that metabolic alkalosis would be compensated for by a CO2 retention, right? Now, 2 things about that. One is that any CO2 retention in the body stimulates the respiratory center. So the awake, conscious individual never compensates for metabolic alkalosis. I'll say that again. The awake, conscious individual never compensates for metabolic alkalosis. CO2 retention does not occur as compensation for metabolic alkalosis in the awake and conscious patient. Even if when it does, PCO2 will never exceed 55. Okay, and the relationship is not linear. We've discussed that in greater detail where we've discussed metabolic alkalosis in the ABG section, right? So these three were the options that you should have chosen, right? Let's move on. Ventilatory settings is slightly, I won't say tricky, but I would say a little complicated, right? So they gave you a 50-year-old man intubated for acute pancreatitis related complications. Ideal body weight is 70 kg. Ventilatory settings are a tidal volume of 420 ml. Immediately you should come to know that they are using 6 ml per kg body weight. So that means they are using a low tidal volume strategy. And what is the complication that would have occurred in acute pancreatitis to lead to intubation is ARDS, right? So they've kept a respiratory rate of 14. The FiO2 is at 90%. They're using a PEEP of, so this combination of low tidal volume plus high PEEP is called open lung ventilation, right? Because there is a surfactant dysfunction in ARDS. What we try and do is we keep the alveoli inflated even during expiration, right? And prevent their collapse and therefore prevent further injury. Okay, so this strategy is called open lung ventilation. It is the best strategy for ARDS, ventilatory strategy for ARDS patients. Okay, and they've given you an ABG which shows that the SpO2 is 100%, PO2 is 110 millimeters of mercury, PCO2 is 48, and the pH is 7.33. The combination of a slightly high CO2 and a slightly low pH is called permissive hypercapnia. Okay, that means that you are allowing CO2 to accumulate because you don't want to see. What would be the way to reduce this CO2 is either you increase the tidal volume or you increase the respiratory rate, right? Now what's going to happen if you do that is that what we are trying to prevent, further alveolar injury, will start to occur, right? So you don't want to do that. Okay, you allow CO2 to accumulate up to a PCO2 of 50. You allow the pH to go down to 7.30. That's permissive hypercapnia. So this is perfectly all right. They've asked you what you want to do next. I just told you you don't want to increase the tidal volume because that might cause damage to the alveoli. Increasing PEEP have been necessary if the patient were not maintaining saturation despite a high FiO2. That would have been the indication of increasing PEEP, positive end expiratory pressure. So that's not the case. You don't want to increase respiratory rate. Again, same issue. You don't want more alveolar injury. You want adequate ventilation and oxygenation, and this permissive hypercapnia, because the pH is 7.33, you're okay with it, right? So what you want to do is that oxygen toxicity in the adult, oxygen toxicity to the lung in the adult can cause further, it causes reactive oxygen species to get generated and therefore further tissue damage occurs, right? So what you want to do, see, ventilation, when you're ventilating a patient, what you want is a saturation of between 90 to 94%, right? You don't want more than that. You know that at this, the PO2 is still 60, and at a PO2 of 60 or above, at a saturation 90 to 94, PO2 will be 60 to 80. And at that PO2, tissue oxygen requirements are being met, right? So you don't want, what you don't want is a PO2 of 110, because you don't want more reactive oxygen species which will cause further alveolo-capillary membrane damage. So what you want to do here is reduce FiO2. Typically, when we start ventilating a patient, when we initially intubate and initiate ventilation, we give a PO2 of 100, FiO2 of 100%, right? We don't know how the lung will respond. So we gave an FiO2 of 100% and we watch the SpO2 very closely like a hawk, right? Once you establish that, hemodynamics are stable, you start to reduce the FiO2 fairly quickly, right? You don't give a high FiO2 for too long because of oxygen toxicity that can develop even in the adult, right? So that was the answer there. That's why I said it's a little, complex. So that's how that works. Let's move on. Pneumoconiosis, simple question, thankfully. So they're asked you to match how these different pneumoconiosis, mesothelioma, or one of their complications, asbestosis, sarcoidosis, and Kaplan syndrome have what corresponding features do they have? So mesothelioma, if you know anyone, then that's how you can start working it out. So mesothelioma, looking for its answer, it causes a pleural effusion without mediastinal shift. Very, very important. Why? Because the tumor fixes the mediastinum. It's a pleural tumor, right? So pleural based tumor, very fibrous in nature. So it fixes the mediastinum. Even with a massive pleural effusion, it will not allow the mediastinum to shift to the opposite side. Okay, so that's mesothelioma. Asbestosis is predominantly lower lobes are affected in asbestosis. So this is asbestos. Sarcoidosis, you see a crazy paving pattern on the HRCT, and this is a crazy paving pattern basically. If that's the HRCT and that's the lung, what you will see is patches of alveolitis with thick septae. So thickened septae in between, like the paving of, like stones that pave a driveway, right, or a garden path. This is crazy paving pattern seen in, can be seen in sarcoidosis, can be seen in a lot of other diseases as well, right? It's very typical, for example, for pulmonary alveolar proteinosis. Okay, Kaplan syndrome, the combination of coal workers, pneumoconiosis, and rheumatoid arthritis. So initially seen in coal workers. So that was a simple, straightforward question for most of you. And then I would call this a tricky question. A 53-year-old woman, right? They gave you a 53-year-old woman evaluated for daytime sleepiness, memory loss, which have been present for the last 1 year. BMI is 43, BP, she's hypertensive, the awake ABG shows a slightly low PO2. PO2 of less than 80 is hypoxemia, and PO2 of less than 60 is type 1 respiratory failure. So a slight mild hypoxemia, a hypercapnia. This is a daytime PCO2, awake PCO2, okay, and a bicarb of 33. So that means there is a metabolic compensation for this respiratory acidosis as well. Now, what's the diagnosis? What instinctively most of us would tend to think of is obstructive sleep apnea, right? That's what we would want to think of. Now, this is where they played with you. See, what happens is that for a diagnosis of OSA, you have to have apneic or hypopneic spells that correspond with a fall in PO2 or SpO2, right? SpO2, practical reasons. So what that means is you need to do a polysomnography to make that diagnosis. This, until we do that, this is obesity hypoventilation syndrome. Most patients with obesity hypoventilation syndrome have OSA, right? But that diagnosis cannot be made without a polysomnogram. So the answer to this question is not OSA, it's OHS, obesity hypoventilation syndrome. Central sleep apnea is a disorder in which the patient chronically hyperventilates when awake, right? So they wash out carbon dioxide when they are awake, right? So chronically hyperventilates during daytime when they're awake. As a result, carbon dioxide gets washed out. So when they go to sleep, right, when they're awake, their wakefulness maintains their respiratory drive partially. When they go to sleep, that wakeful that the awake respiratory drive is gone. So respiratory drive then depends only upon carbon dioxide, which is getting chronically washed out, right? So therefore, in their sleep, they tend to develop hypoptic or apneic episodes. It remains until in the few seconds that CO2 accumulates, again stimulates the respiratory center. The respiratory center is again hyperventilates, again brings it down to a value where that drive is lost. And again, since the patient is asleep, goes into an apneic or hypopneic spell, CO2 accumulates for a few seconds, stimulates the respiratory center. Once again, the hyperactive respiratory center in a patient with central sleep apnea excessively overfunctions, washes out carbon dioxide, and that continues. That's central sleep apnea. So if they had given you a patient with an awake PCO2 of 30 with sleep apnea, with these findings, memory loss and daytime sleepiness, then they're talking of central sleep apnea. Okay. So if you got that wrong, I'm so sorry for you, but that's how it works. Severe community-acquired pneumonia. They had given a patient, 35-year-old man, with no significant past medical history, right? No significant past medical history. Being treated for severe breathlessness. He's febrile. Saturation is low despite being on 6 liters oxygen with a nasal cannula. So nasal cannula at 1 liter per minute gives 24% oxygen. For every 1 liter added above the first liter, the FiO2 increases by 4%. So for 6 liters, the nasal cannula is giving 24 plus 20. So it's not 44, actually it's 40%. The nasal cannula is unable to give more than 40% oxygen. The reason for that is it's a low flow oxygen system. It can't meet volume requirements. Minute volume requirement can't be met. So you've seen patients, if you've seen a patient on a nasal cannula, and you must have given the recent COVID pandemic, you will see, you obviously have noticed that the prongs are inserted into the nostrils. The patient is breathing in what is delivered by the prongs, which is oxygen, and also breathing in room air. So this mixture of room air with the oxygen supplied by the nasal cannula reduces the concentration of oxygen being actually delivered, and therefore nasal cannula is unable to deliver more than 40% oxygen. So if you give more than 5 to 6 liters per minute oxygen with a nasal cannula, you are just drying up their nasal mucosa very fast. You're not giving more than 40% oxygen. Anyway, so you're giving 40% oxygen and SpO2 is 87%. So an SpO2 of 90% is usually correlates with a PO2 of 60 millimeters of mercury. Below that, an SpO2 of less than 90 or a PO2 of less than 60 are respectively the definition of type 1 or hypoxemic respiratory failure. So if this patient is at a saturation of 87%, my understanding is that PO2 would be, and the OHDC has a sigmoid shape. What does the sigmoid shape mean? It means that if this is hemoglobin saturation with oxygen and this is PO2, then between 90 and 100, if this is 90, then this is 100 saturation. And you see here, there's a big difference. This is 100 and this is 60, right? So down to a PO2 of 60, hemoglobin is still 90% saturated, which is why oxygen requirements are being met. Below this value, there is a precipitous and faster fall in PO2. Okay, so that's why this point is the definition of respiratory or type 1 or hypoxemic respiratory failure. So at an SpO2 of 87, my understanding is that PO2 would be, let's say, 50. And so what's the PO2 FiO2 ratio is 50 upon 40, which is 50 upon 0.4 really, because FiO2 is 40 upon 100. That's how you express FiO2. When we say FiO2 as a percentage, it's not really correct. So 50 upon 0.4 is the PO2 FiO2 ratio. What does the PO2 FiO2 ratio tell you? It tells you how well oxygen is diffusing across the alveolo-capillary membrane. PO2 is that value which the patient has. FiO2 is the in their blood. FiO2 is the concentration of oxygen you are administering to the alveolus. What's there between them is the alveolo-capillary membrane. So how well is oxygen diffusing across the alveolo-capillary membrane is told by the PO2 FiO2, which is ratio, which is why you use it to assess oxygenation, you use it to define ARDS also. So that works out to 125. So severe ARDS. Correct. So that's what this patient is having. Let me take that away for you for now. So going back to the question again, 35-year-old man, no significant past medical history, severe breathlessness, fever, a low saturation despite oxygen, oriented only to person, is confused, right? And TLC is high, serum creatinine, right? So that's creatinine is also mildly high. Sputum shows 2+ pus cells and 1+ epithelial cells. Rhinovirus is demonstrated in the anterior nares, which has no consequence whatsoever. Which of the following should be administered? So what you're dealing with here is severe community acquired pneumonia, right? What tells you that this is severe? This tells you another thing that I didn't quite mention, I forgot to mention here, is that they had given a respiratory rate of 33 per minute. So a respiratory rate of more than 30 per minute means severe pneumonia. A saturation of less than 90% means severe pneumonia. Multilobar disease is often severe pneumonia. Confusion is severe pneumonia. Azotemia is evidence of severe. So there are several evidences there that tell you that this is a severe pneumonia, of course, and the objective evidence, which is PO2 FiO2 ratio. So what should you give? Now here's where my confusion comes in, right? And I'm sorry I can't help you with that. Those were the choices. I remember them very well. I was foxed. So the option for severe community acquired pneumonia without risk factors for either of MRSA or Pseudomonas aeruginosa, severe community acquired pneumonia without risk factors for MRSA or Pseudomonas aeruginosa. So that's why they told you no significant past medical history. If they had said, this patient had been on antibiotics for a while, if they had said he had recently been hospitalized for something, if they had said he's on maintenance hemodialysis, then, or he's getting a wound dressed at home, then those are risk factors for MRSA or Pseudomonas aeruginosa. Now, none of those risk factors is present. How do you treat that severe community acquired pneumonia of such a type? You give them beta-lactam with macrolide or beta-lactam with a respiratory quinolone. So that's beta-lactam with a macrolide, and that's beta-lactam with a respiratory quinolone. Now, what to choose among them? If you guys understand this, please write in as comments to this video. I'd be happy to discuss. But for now, I'm foxed how to solve this question. I gave you everything. I gave you the information, how it is to be dealt with. And unfortunately, I don't have a definitive answer for you. Very happy to discuss. Okay, I'll move on for now. So what my advice for so-called controversial questions is that find out as much as you can about the theory surrounding that topic. When you go to the exam, look at the question more carefully. See, these are recall questions. Maybe I forgot something that's important to make that decision, and that would inform me whether to use ceftazidime, azithromycin, or ceftriaxone, levofloxacin, right? So that's how you deal with these so-called controversial questions. Don't get into those controversies, but read up the theory around those topics very, very much in detail and from your standard reference textbook. Okay? Right. Coming from me, that should mean something. Okay? All right. Severe COVID, another problem. Okay. So as far as I remember, please correct me again as comments if I'm wrong, this was not a multiple correct question. So they had asked which of the following does not qualify as severe COVID. A respiratory rate of more than 30 does qualify as severe COVID. A saturation of less than 90% on room air does qualify as severe COVID. Now, a CT involvement of more than 50% is what defines severe COVID, right? So that is definitely not one of the features of the criteria for severe COVID. And my problem comes here is that mean arterial pressure between 70 to 100 is normal. So again, and in fact, when you look at definitions and criteria for severe COVID across guidelines, you don't find mention of mean arterial pressure anywhere. So maybe they were talking of critical illness, right? Critical COVID is where you have shock, etc. So if I were you and I were given the same question again, single correct answer, what I would say is, since they're talking of severe COVID and not critical COVID, I would say that this is not severe COVID. But obviously, this is also not severe COVID. So that's again something I'm very sorry I can't help you with. You have something on that, please write in, call us, write down as comments, and I'll be happy to discuss. Okay. Now, this was a question which was, the answer is straightforward. I think it's a tough question. Oxygen content of blood is plotted against PO2. So this was the y-axis was oxygen content of blood, right? This y-axis, the oxygen content of blood, and where this was, let's say, I don't remember the units. If this was 100 units, then this was fairly low. So this was about 50 units. So very big difference between the two graphs. And they had said the dashed graph represents the normal adult. What does the solid graph represent? And the choices were the 4 types of hypoxia, right? So what would happen to this graph in, let's say, hypoxic hypoxia, right? So if that's the y and x-axis and that's the normal graph, and this is 100 units, whatever units they were, for oxygen content of blood, right, 21 ml per deciliter, right, maybe. So then what's hypoxic hypoxia? Where the available FiO2 is low. That's hypoxic hypoxia, or it's poorly diffusing across the alveolo-capillary membrane, as in let's say interstitial lung disease. So what would happen is that there would be hypoxemia, but it would not be of this degree, that only about 40 to 50% of oxygen carrying capacity of the blood is being fulfilled, right? What carries maximum amount of oxygen in blood is hemoglobin. So any disease that's reducing the oxygen carrying capacity of blood by about 50% or more has to be a disease that is affecting hemoglobin availability. So that means the question there was obviously on anemic hypoxia, right? So what that means is that if instead of that they had said, carbon monoxide poisoning, that's also a type of anemic hypoxia, then that would have been the correct answer. Of course, you understood now, I hope. The answer was anemic hypoxia, and I explained why. Because the degree of fall in the content of PO2 is so high that can only happen in anemic hypoxia. Another information given was that these dashed red lines here, this thing is the arterial blood, whereas these blue lines here is the venous blood. So the tissues are able to extract enough oxygen from what is being supplied to them, right? Which would not be true for histotoxic hypoxia. So in histotoxic hypoxia, there won't be much of a difference between arterial PO2 and venous PO2. That would be the kind of graph that you would get. Okay, right. And in none of the other types of hypoxia, hypoxic, stagnant, or histotoxic, would hemoglobin be unavailable for binding oxygen? Can you think of any other condition where hemoglobin would not be available? Methemoglobinemia. Okay. Anything else that's much more common? Anemia. Severe anemia would also produce such a graph. So if the hemoglobin is 7 and normal should be 14, oxygen carrying capacity is halved, which is why these patients get tired so easily. Okay. So that's why I said the answer is straightforward. It's very clear, unlike some of the controversies that we just discussed, but I think it was a tough question. Okay, moving on. Aortic regurgitation murmur. Again, I don't think this is a very straight question. What they had asked was, we all know that the AR murmur is an early diastolic murmur. And when you think of early diastole, what's the first thing that would come to mind? Is isovolumetric ventricular relaxation. Correct? That is incorrect. Now what happens is, and I'll show you the cardiac cycle in a minute. See, what happens is that you hear the S1, then there's a gap, or there might be the Austin-Flint murmur, right? And then you hear S2, and right after this, there is the decrescendo blowing murmur of AR. That's heard in what area? That's heard in A2 area. The reason I'm talking about A2, I'll come back to it, right? I think next question itself, again, nasty trick. In fact, I'll explain in detail there, but going back to the AR murmur, the early diastolic murmur of AR is heard here after the second heart sound, right? So what happens, another thing that happens in AR is that the ventricle gradually starts to, see, the ventricle is hypertrophied because it has to pump out a lot of volume. End diastolic volume is very high. It starts to get higher because whereas the left ventricle should be able to pump out blood effectively, and that should not come back from the aorta, in aortic regurgitation, what's pumped out by the left ventricle is also partly returning to the left ventricle, right? So that's aortic regurgitation. So at the end of diastole, the blood volume is increasing. So to be able to pump that out effectively, and there is hypertension, mind you, in these patients, the left ventricle hypertrophies, right? So that means it becomes more stiff. Now let's look at the cardiac cycle, right? The blue curve there is ventricular pressure, and the red curve there is aortic pressure. What would cause the murmur? A gradient in pressures between ventricular pressure and aortic pressure, right? So that's where the aortic valve should close, here, right here. Okay, now it's not closing, and in this phase the ventricular pressure is still falling. Correct? Now you think of a stiffer, and this is where these are the first and second and third heart sounds, right? So that's the second heart sound, right? You correlate with this with a stiff ventricle with pressures that are, even in the normal individual, there's not a big gradient between aortic pressure and left ventricular pressure. I erased those markings for you so that you can see the delta, the gradient between these two pressures. So when you hear the murmur of aortic regurgitation is here, which is the phase of rapid inflow. If you got that wrong, I'm so sorry. It was a nasty trick, right? So the answer is during rapid filling phase. You can trust these guys to do this. Okay, I hope you got that. What I would want you to do now, instead of being upset and bawling over this, work out the murmurs for all the valvular diseases with respect to the cardiac cycle. Okay, it's not an easy task. Okay, now this is the second question I was talking of. Consider the following areas for CVS examination. And they're talking about pulmonary area, aortic area, and mitral area. And they've asked the lead-in question, quote unquote, during examination, what is the sequence, superior to inferior, of these areas of the left chest wall? If you missed left chest wall, you got this wrong. If you missed reading left chest wall, you didn't get this right, isn't it? So if that's the manubrium and that's the sternal body, right? The second rib, right? This is the aortic area. This is the A1 area. This is the pulmonary area. This here is A2 area. The second aortic area where you hear the murmur of AR. We just discussed that. And then beneath the aortic area, the left fourth intercostal space is the tricuspid area. And then mitral area is in the fifth intercostal space, 1.25 centimeter medial to the mid-axillary line, right? So in sequence, first pulmonary, right? First pulmonary, second intercostal space, third intercostal space, A2 area. They had clearly said left chest wall, and when I read that, I gave the exam. And when I read that on the paper, I said, you nasty people. So because a lot of kids will not think of the A2 area, they'll just not read left chest wall, they'll go aortic, pulmonary, mitral. But that's not what is correct. They're talking of the left chest wall, so first, second, and third in that order. Moving on. Okay. Minor NADA's criteria, thankfully, straightforward question. Congenital heart disease, nevertheless, so I won't move a lot of time on it. Abnormal BP and abnormal second heart sound make up the are part of the minor NADA's criteria. A systolic murmur of grade 3 or more, any diastolic murmur are major NADA's criteria, besides cyanosis and congenital heart failure. Besides abnormal BP and abnormal chest X-ray or an abnormal ECG are also minor NADA's criteria. A systolic murmur of grade 2 intensity is also minor NADA's criteria, right? So just listed those for you, okay? If you want to, you can maybe pause this and note those down, okay?